good morning, and rather good day, depending on which part of the world you are or which part of the night or day it is. So, welcome to Oral Pathology 360, what we hope is the home of oral pathology on the web today. Now, I'm an oral pathologist and creator. I have also been an academician, researcher, and clinician. So, what I have found in all these years is that oral pathology, although very important, but is not by itself one entity. It's a part of a bigger entity, and that's dentistry, which is itself a part of the bigger entity of healthcare. So, here we are basically to just promote all of that together. And I'm glad that you are joining us on this. Of course, once in a way, we have very sad news also to bring together and to go through. So, this week we have a sad news of passing away of one of our colleagues. Dr. Himani Sukija passed away last month. She was the head of oral pathology department at the Index Dental College Indore. Yes, sadly, I never really got to know her. I found out about this through Dr. Nandini, who was her batchmate. But I can say it's very sad. She, from whatever I've seen and read, she was a very nice, very kind, and very thorough. And what I would say, somebody said she was the tiger of oral pathology. So I don't know, but definitely I can only say that she must have been really very close to her students and to her colleagues. And we have lost a gem. And sadly, some of us did not get to meet her during that time. So she will be fondly remembered. Now coming to today and dentistry special. I know many of you have heard this statement, as is our oral pathology, so is our practice or our dentistry. And you might be wondering, as a dentist or as a clinician, you might be wondering, is this just us oral pathologists being extremely optimistic and loving of our own job? Or is it actually something that is true? So, if we had to find that out for a fact, whether it is or it is not, we have the absolute right person today. Somebody with extensive clinical experience and in-depth knowledge of oral pathology that can who can answer this question, and that is Dr. Ranganathan. I'm very happy to have you here, sir. And to just give you a background, he has been a clinician probably longer than he has been an oral pathologist. And he is the head professor and head at Raga Dental College and Hospital, Chennai. He is also currently the International Association of Oral and Maxillofacial Pathologists Secretary, and he is also the president of the Asian Society of Oral and Maxillofacial Pathologists. And he has basically been into research, clinical practice, everything. And it is very common for me when I talk to him to hear him talking about basically, oral pathology, but also in terms of practice, how it affects practice. Every one of us have heard him talking and have heard him saying things like that. So today, here with us, he is going to share those details. Some things for everybody to take home, whether you are a dentist, a dental specialist, a student, or an oral pathologist. Welcome, sir. Thank you for joining us. Sir, where are you?
You hear
Oh,
me?
okay. Yes, I can. Yes.
Yeah, I've just shifted my
Okay.
thing to low data mode because I think having some issue with Wi-Fi, and because I'm from the institution, and I
Yes.
think everybody logs on because we have online class. Thank you for the kind introduction. Before I go on to my slides, it's myself and Dr. Mandana got to discussing. Is my audio clear?
Yes, sir. Yes.
Yeah, and she was very clear. Uh, First, she said it should be clinically oriented because we keep talking about, as is oral pathology, so is your practice, and we have tons of stuff on research on this website and on her program. So she said it should be very clinically oriented. And the second thing she quickly said was not much of histopathology slides. Then I said I need to put in histopathology slides. I'm a pathologist. I shouldn't forget that. So what I've done is I've compiled a few cases over the period of years from my files to drive home certain very, very important caveats in practice, and how, as we as oral pathologists, can help ourselves in practice and interact with people from other specialities, actually. And some of these cases are from our colleagues from other specialty. And hopefully this will be eye-opening. And if some of my students are there, you might have seen these cases over a period of time. And I use these to talk to general practitioners. Okay. With that very brief introduction, let me start. We start this sort of interaction with these two conditions, that these are all clinical cases that I have collected from my office over the period of years, and drives home certain important caveats in diagnosis, and also our interaction with colleagues from other specialty. Okay. All right. Okay. Now, these two go hand in hand. That goes without saying. Any clinical diagnosis should be supported by pathological diagnosis. Pathology, in turn, if it doesn't have a clinical background, has got no use to the patient. And never lose sight of the fact that patient management is the goal. It seems pretty obvious to make the statement, but sometimes we split so much hairs on classification, just necessary at certain level for us to understand the pathosis more better, but may not be significantly different as far as patient management is concerned. Okay. And just like in pathology, in the clinical context, there are cases could be cubbyholed into three different groups. One, you look at it, you know what it is. For example, an aphthous ulcer, it's pretty straightforward. I mean, you don't need a second opinion on that. Second, you look at something and you have no clue what it is. Absolutely no clue. For example, there is a deep swelling in the buccal mucosa. There could be tons of things which it could be. Then that should be, you need to do a lot of workup to come to a diagnosis. Finally, you have a huge differential lesion, this sort of, you see something which is reticular and white in color on the buccal mucosa. It could be lichen planus, it could be lichen mucositis, it could be an oral manifestation of lupus erythematosus. I mean, you have a huge list of differential diagnoses, which you should narrow down before you eventually treat the patient. So the first time you see a patient with an interesting case which has been referred to you, I mean, you make up your mind into which group this falls into. Okay, with that background, let's go to the cases per se. Right from when you did your general medicine and had training in medicine and surgery, there's been a lot of emphasis on history, and I cannot overemphasize this again and again and again, because sometimes we look into the oral cavity and get so caught up in it that we forget that the oral cavity is connected to a huge body with multiple organ systems. So systemic features are very, very important. And that's what this case is going to drive home. Okay, this was a case of a patient with a periapical radiolucency. And let's see what blood pressure has got to do with that. Many years back, this was about 6-7 years back, this was a woman in a second decade. And if I remember well, she was about 19 or 20 years old. She had a pain and swelling in the left upper vestibule, had extensive restorations, with a history of amylogenesis imperfecta. These were the details I got along with the biopsy specimen. What exactly was biopsied? You're looking at an occlusal radiograph. You see a radiolucency of extensively restored teeth. And these have been restored because the patient has amylogenesis imperfecta. And you can see this panoramic view showing extensive restorations being done. But the problem was, this was done a year or so back, and now the patient has landed up with the conservative dentist with this radiolucency and this swelling in the vestibule. So this was referred to the surgery department. And, excuse me, it was cleanly excised out, a nice, well-circumscribed lesion. And histopathology is pretty straightforward. I'd like to draw your attention to multiple chain cells and a very straightforward diagnosis of a giant cell granuloma of the central tongue. So, fine. The clinician is happy, the patient is happy that it is not something ominous. We said giant cell granuloma, and the clinician wanted to know, I have removed everything, Patient is healing very well. Is that it, or do I need to do anything else? And if you remember what you were taught in oral pathology in your third year, as far as India is concerned, the first thing we tell is the moment you diagnose a central giant cell granuloma, the next thing should be rule out hyperparathyroidism. And that's what I told the clinician to get the parathormone levels done. We got it done. It was extremely high. And I'm sure you're all aware of the features of hyperparathyroidism. There are multiple features. And one of the important features is it's associated with renal calculi, renal dysfunction, and a lot of renal problems, which can affect the function of your kidneys. So the moment this was high, there are two things which I told the clinician immediately: get the blood pressure of the patient checked. And I'm sure almost all of you are aware that hypertension and the renin-angiotensin system involving the kidneys have got a very, very, very close relationship. In fact, even before renal function was done, the patient's blood pressure was taken and it was extremely high. It was something like 200 by 110 or something like that. And then a series of tests were done and all the renal parameters were abnormal. And she had a very, very chronic renal dysfunction. Blood pressure was extremely raised, and then renal disease was diagnosed, and the patient apparently wasn't aware of this. And this is what was very interesting. The patient did not have any clinical manifestations, and she had episodes of giddiness or dizziness, and she attributed it to not eating correctly or probably a transient hypoglycemia because of irregular intake of food. And because she was pretty young, and nobody suspected that she would be hypertensive. So eventually, renal disease was diagnosed, and the patient was subsequently treated for her renal problems. And this is an interesting association, amylogenesis imperfecta with renal disease. And in fact, from our center, we have published quite a few years back, way back in 2007, a report of 2 cases. And subsequently, there are numerous reports about this combination. But what is very interesting in this case is the fact that the patient had a periapical lesion. We went on to diagnose a giant cell granuloma, which led on to a series of investigations in which the patient's renal condition was diagnosed and the patient was treated for it. So the take-home message here is always be very, very aware of systemic issues, systemic problems. Whatever problem the patient may have in the oral cavity, do not lose sight of both history and the thorough clinical and the systemic examination of all important parameters, no matter what the age of the patient is. Okay, moving on to the next case. This is once again a very interesting case, and I always go through this case whenever I feel a little bit overconfident with my diagnosis. Very, very interesting sequence of events. And the message here is, whenever in doubt, always investigate. Don't take things for granted. Okay, this is how I start this slide when I talk to clinicians. When is a headache just not a headache? Because headache and facial pain is one of the most difficult things to manage in clinical practice. As I'm sure you're all aware, those of you who practice, there's a huge list of differential diagnoses, huge set of tests which you can do and eliminate reasons. This was a woman in a 4th decade. She presented to us, she was referred to me with vague pain, and what she felt was a swelling in her left cheek with headache. She had seen numerous medical professionals. By the time she landed up in my office, she had seen ENT folks, she had seen neurophysicians, she had seen multiple physicians, and she had a huge list of diagnoses for which she was treated: migraine, sinusitis, myofascial pain dysfunction, mild, unilateral headache, as multiple conditions she was treated. And she did get relief for a few days to weeks with these medications, but eventually the pain came back. And this is what she looked like when I looked into the oral cavity. If you look very carefully, you could almost see a swelling. And the best way to look at it is You can see some stippling here, a loss of stippling here. There was a little bit of a swelling, a supra-eruption of the, excuse me, of the upper molar. Fairly good oral hygiene. I mean, she has undergone multiple oral prophylaxis, excuse me, thinking that there could be some dental problem for the headache and pain. So this was the swelling there, very, very subtle. And we took a panoramic view. Of course, today you would take a CBCT because almost everybody takes a CBCT where the results are a little bit more clear and sharper. But even in the conventional panoramic radiograph taken quite a few years back, you could make out the change in the density of the bone. If you look at cancellous bone, this is almost dense, maybe well defined, not exactly involving the maxillary sinus. This is a higher magnification of that particular region. This was the molar which you had seen, which was supra-erupted clinically. Retro to the molar, and these teeth have been also extracted. The second and third molars been extracted, and that was one of the treatments she underwent for the pain, for the non-specific pain. And this is the floor of the maxillary sinus, and you can make out that there is some change in the texture of the bone. It's a little bit more dense, not as cancellous as how the maxilla normally is. And then you can make out these small punched out radiolucencies right there. And with the clinical and histological and, the radiographic appearance, I still didn't have a diagnosis. I told the patient that there is definitely an alteration. So this is not a psychosomatic problem, for the mere fact that the symptoms which she have is associated with some organic change within the bone. A lot of times when there's a psychological background to pain, it keeps moving from one place to another, and there is nothing organic we can really pin down on. But in this situation, the patient had headache on that particular side. There was a subtle swelling, and there was alteration in the bone. The only thing I could think of was something like a chronic sclerosing osteomyelitis, probably associated with the pathosis of the teeth, which were extracted and still not healed. Then there is a condition called NICO, neuralgia induced by cavitational osteonecrosis, very, very controversial diagnosis to make in the head and neck region. I think we'll talk separately about that issues associated with that diagnosis. But our orthopedic colleagues make this diagnosis in long bones. And that was in my differential diagnosis. So we worked with the surgeon, and I told the surgeon, why don't you go in, curate it off, and submit the sample to me? Maybe, the vascularization caused by the surgical procedure may generate healthy bone, and she can overcome the pain associated with the nerve fibers in these modified pathologic area of the bone. We took a biopsy, and to my surprise, it was just uniform sheets of blue cells. I was really taken aback, and we did a whole panel of markers. And suffice it to say that with the markers, we came back with a diagnosis of leukemia. And we referred it to a hem-onc person, and they classified as acute myelomonocytic leukemia, FABM4 type. This was a few years back. And the interesting thing about this case was that they did a complete body workup, and apparently there was no other identifiable problem elsewhere. And the patient was subsequently treated, and a year after the treatment, the patient was doing very well. I lost contact with the patient subsequently, and I hope she's doing well, but she had total recovery. And this was one of the scenarios in which even when you feel that the symptoms are very vague and not something which you should follow up extensively, it's still important that you do it. And we were able to diagnose this pretty early in the patient. And fortunately for her, she did not have any major systemic issues, was treated very aggressively and did well. Okay. Now we move on to another interesting case. This is a case of a rapidly growing black lesion. This is interesting because this was one of my students. He was a conservative postgrad, actually, a student in my institution. He walks into my office one day and says, Prof, I have this rapidly growing black lesion on my cheek. I'm extremely scared. I'm not able to sleep. It has been there for, a week or so. And he was extremely upset about it. So he was in the second decade, black pigmentation, a few weeks, not on any medication, did not have any habits at that point in time in which he presented to me. Apparently, he was an occasional smoker a few years back. And this is what I saw. There was a diffuse black pigmentation of the buccal mucosa. We're looking at the tongue. We're looking at the lower molars. Right there. This is the opposite side, the contralateral side. Mucosa looks absolutely normal. Okay. Then I asked the history, and he said, I had a few amalgam restorations. I had it taken off about a few weeks back and replaced them with glass ionomer tooth-colored restorations. And subsequently, a few days after that, this pigmentation started developing. And do you think it's allergy? It was not an allergic reaction because one, glass ionomer very rarely causes an allergic response. Composite resins, yes, I've seen a few cases of contact stomatitis associated with composite restorations, but I actually haven't seen much with glass ionomer. And he had glass ionomer restorations elsewhere in his oral cavity, and he was absolutely fine. There's this one particular area. Then, given the history that the amalgam restoration was removed and subsequently he developed this pigmentation, he was asking me whether it's amalgam tattoo. Amalgam tattoo does not form that quickly. I mean, it needs to seep into the connective tissue, stain the collagen fibers and fibers which are turning over. So it does not happen like that. You may get particles of amalgam, but you don't get diffuse pigmentation like this. I told him, no, there's this one condition. This is what it is. Don't worry about it. It's because of the trauma, mild trauma when the restoration was done. Most probably when you had an isolation, they must have the instrument must have, or the burr or the cotton fiber must have physically caused a trauma on your buccal mucosa. And he said, yes, there was a little bit of a burning sensation immediately after the restoration because, the rotary instrument had slightly touched his cheek. But he didn't think much about it. He said, no, I need a biopsy. I said, you don't need a biopsy. He said, no, take a biopsy. And I said, good. It's quite some time since seen a histopathology of this particular lesion. And we took a biopsy. And you can see sutures here. And when he came for the suture removal, actually, you can see that the pigmentation has started disappearing right there. This is very unique about this particular lesion. It is induced by trauma, usually following a restorative procedure. And many a times it will spontaneously disappear. And if you do not know what the diagnosis is and you do a biopsy, it confirms the diagnosis and also makes the pigmentation disappear many a times. So that's a good thing about taking a biopsy in this particular region. I'm sure many of you have guessed what the diagnosis is. This was a case of melanoacanthoma. What actually happens is there is a lot of acanthosis in the surface epithelium. And this is a special stain for melanocytes, the Meson-Fontana stain. And you can see a lot of these squiggly structures right here. These are the melanocytes and the dendritic processes. And there's a lot of melanin being produced. So melanoacanthoma is a condition in which, because of trauma, not all trauma, certain trauma in certain people induces a rapidly arising and progressing pigmentation, usually the buccal mucosa, invariably follows a procedure, restorative procedure in the oral cavity or any minor trauma. It is upsetting because it is dark in color and it grows very fast and satisfies many of the criteria of a melanoma. But invariably, it's just a discoloration. There is no thickening or a plaque formation or an infiltration or an induration. Usually, it is self-limiting. If you take a biopsy, you will see acanthosis and tons of melanocytes. And many times, the biopsy itself will cause the lesion to absolutely fade. We went ahead and reported this case of an oral melanoacanthoma, and we reviewed the literature. And this is one of those few lesions which, if you know what it is, you know what it is clinically. Otherwise, it's very difficult to diagnose, and you need to biopsy it to confirm your diagnosis. Okay, the next case is once again very interesting and also drives home the fact that with passing years, habits change, the norms and most change. So we have to be updated on many fronts when you're practicing pathology, clinical dentistry. It's a very interesting case a few years back. This was a 33-year-old male patient. He reported to me with patches and burning of his anterior dorsum tongue. The burning was worse on taking spicy food. He was an IT professional. He was working in the IT industry. The duration was 3 months. He had a metabolic syndrome. He had early type 2 diabetes mellitus. He was a little bit overweight. No family history of diabetes because of his lifestyle associated with his work. No habits. He did not smoke. He did not chew any tobacco or areca nut. No relevant habits which are of topical implication. He was diagnosed as having lichen planus and was given some steroids. He said that the pain was still there and the pain was gradually worsening. And this is how it looked like. And I looked at the dorsum of his tongue. There were these, white plaque-like areas, a little bit of erythematous areas, a few lesions in the buccal mucosa, but not as dramatic as what was there in the dorsal surface of his tongue. I really didn't know what it was. Does not look like your classic lichen planus, maybe chronic ulcerative stomatitis, but did not fit into that typical picture. We took a biopsy and we saw some split, no lichenoid reaction, no classic histopathology of lichen planus. There was an ulcer. You're looking at surface epithelium. There was an ulcer. But significantly, not much of inflammatory cell infiltrate. Usually when you see an ulcer in the oral cavity, there are tons of neutrophils. There are tons of mixed inflammatory cells. Relatively less inflammation. There was an artifactual split. That is absolutely artifactual because it's suprabasal. And look at this split you're looking at here. And the connective tissue didn't show a marked inflammation at all, which you'd normally expect to see in an ulcerated lesion on the dorsal surface of the tongue, or for that matter, any part of the oral cavity. And one thing which quickly ran through my head was, I was looking at some sort of an immunosuppression. The patient was not immunosuppressed. He was a controlled diabetic. He was taking a few medications for diabetes. Doesn't look like a drug-induced any allergy because of his medications for diabetes, because he was taking that for quite some time, and this was of a very recent onset. But what was interesting was this sort of artifact and this sort of change in the connective tissue. I have seen in tissues when I was in the US, when they post specimens over the weekend, especially in winter, and when the tissue freezes, you see certain artifacts in the mucosa, what we call as a freeze artifact. And sort of reminded me of that. And the fact that there is less inflammation also was very, very intriguing. So I went back, called the patient, and asked him his history. And in fact, I asked him his history about diabetes, basically. Was he totally under control? Was he keeping it under constant check? And got to talking to him. And then I tried to trace back, and I said, when did you actually get this? And then he said, so it was about 3 months back. I had gone to this party in this particular place. The food was very, very spicy. I ate it, and the next day morning, I developed this. Then I said, did you take anything along with that? And then he said, yes, there was this new thing which I tried. Do you think it could be because of that? And I said, what was that? And he said, I tried this drink, which is apparently a craze pre-COVID. Of course, the past 2 years, there's not much of partying going on. This pre-COVID era, and he said this was the craze at that point in time. They had these drinks in which they dipped it in liquid nitrogen, and he consumed a couple of those, and that was actually a liquid nitrogen-induced burn. And he said that he used to take that when he goes out and party because he likes it so much. And he didn't feel any pain because it's so cold, it numbs when he takes it. But subsequently, it caused significant mucosal alterations. And I realized that's how, these recreatory activity involving liquid nitrogen, if you're not careful, that's what happens. I think if there's something like if you take it appropriately, it doesn't happen. I don't know what the appropriate method of taking it is. But this was associated with liquid nitrogen burn. We told him to stay away from it. We gave him some topical application for it to heal, and eventually it healed, and he did excellently well, and the burning sensation disappeared. So this was one of the things also which wake you to the fact that there are new age habits which are coming up, and these may be associated with oral manifestations which you may be seeing for the first time. This is always good to take a complete history, sit and talk to the patient, and find out what's going on. Okay. Do we have time, Dr. Mandana? Can you hear
Yes,
me?
sir. We are well within
Yeah.
time. Yes, yes, we are.
Awesome. So I put this in the last if we had time, I think we have a few more minutes. She said 11:40. I don't want you to go beyond that. Let me see if I can do that. Okay. And no talk of a clinical diagnosis or or interaction between the clinician and the pathologist is complete without talking about oral cancer. And oral cancer diagnosis usually is straightforward in the clinical setting, but very early cases can be tricky, and they can have a very, very atypical or a non-typical presentation. So that's what I normally tell my postgraduates. Oral cancer can have protein manifestations, taking after Proteus, God Proteus, and from the mythology. And you can trip on it if you're not very, very careful. I have two examples of that. But this is a straightforward oral cancer. And this is a straightforward diagnosis. I don't think any clinician or pathologist is going to make a mistake diagnosing this. A buccal mucosa, exophytic lesions, when you palpate, it's indurated. Here, a combination of both exophytic and endophytic lesion, a lot of induration when you palpate. Very straightforward diagnosis. Some of the classic presentations within the oral cavity. Okay, now this was a very interesting case. This patient had this excellent restoration done, had a huge history of multiple gingival infections, periodontal problems. So he had initially a periodontal procedure done. Then it became an endoperio procedure, an endodontic and a periodontic procedure with a root canal and periapical surgery done. Didn't respond very well. Had a fixed prosthesis done, but still the gingiva didn't respond very well. Then eventually an implant was placed, and still had a lot of problems. This was when the fixed prosthesis was placed, and this was removed, and subsequently implants were placed. And you can see that the lateral incisor, which had a root canal restoration along with the central incisor, was retained. Only the central incisors were removed. And the radiographic features were not very marked. So when he was referred to me, we said, remove the restoration, take a biopsy. And the clinician did do that. The restoration was taken out, and there was this really, really bad, unhealthy looking tissue. We went ahead and did a biopsy, and it turned out to be a squamous cell carcinoma of the alveolar ridge. The patient did have habits. He had chewing habits, but the early stages were so subtle and were mimicking gingival and periodontal problems. And I have multiple cases on my files, which we can probably talk as a separate session, where the squamous cell carcinoma can look just like a gingival swelling, a sessile swelling. And it can look like gingivitis. It can look like a boggy swelling of the gingiva. It can be a very, very subtle white patch. And when you take a biopsy, you'll be surprised that it is a squamous cell carcinoma. And I normally present these cases when I do leukoplakia. And a very common question which is asked to me by clinician is, when it's a very, very mild leukoplakia, or what they call a thin homogeneous leukoplakia, the patient has habits. Can I just discontinue the habits and keep following up the patient without a biopsy? Yes, most of the times it is just dysplasia or a hyperkeratosis. But many times it can be very sneaky, and squamous cell carcinoma can look like leukoplakia, actually. So the take-home message is what looks like a leukoplakia can not only be dysplasia, can also be a squamous cell carcinoma. And non-healing gingival and periodontal lesions, even though the radiographic features are not very significant, uh, and you can see that in the periapical radiograph, can still be something ominous like a squamous cell carcinoma. And this patient was effectively treated and is doing very well. And this is one problem which is unique to this part of the world, which I definitely need to present to make it complete from the Indian subcontinent. We see a lot of oral submucous fibrosis. For those of you from the other parts of the world, this is caused by the habit of areca nut chewing, or what we call as betel quid chewing, or chewing a betel nut. The correct term is areca nut, where the patient develops a lot of fibrosis of the oral cavity, and inability to open the mouth, protrude the tongue. It can be fairly debilitating. And it is a potentially malignant disorder, which has a very high, it is a risk of malignant transformation into carcinoma. And this question also crops up frequently because in some parts of our country, there are quite a lot of cases of submucous fibrosis. And because it affects the buccal mucosa, the tongue, the lips, the soft palate, two questions. Do I need to take a biopsy? Because it's a classic clinical diagnosis. And where do I take a biopsy from? Because it's a generalized condition affecting the oral cavity. That's when your clinical acumen comes into play. So the answer to the first question is yes, definitely you need to take a biopsy because it's a potentially malignant disorder. You need to document how severe it is and rule out cancer. Two, where do you take the biopsy from? There are a few signs, like redness, induration, sudden onset of clinical symptoms in a particular area. And we could talk once again a separate session on that. But this case was very interesting. You're looking at the angle of the mouth. You're looking at the tongue which has been elevated, and this is the buccal mucosa. And you can see this white fibrous band. This is how you normally see, but you can also see a red erythematous region right here. So this patient had an erythroplakia. We did take a biopsy, and it was a classic squamous cell carcinoma. So there are two take-home messages here, actually. So if there are any alterations in addition, normally the submucous fibrosis has got a white pallor and these sort of fibrous bands. If you see any alteration like a leukoplakia, an erythroplakia, sudden worsening of clinical symptoms in the patient, definitely needs to be biopsied. And the second take-home message is, as far as the oral cavity is concerned, and this caveat I follow in my practice, anything which is erythroplakic and erythroplakia when associated with a habit, invariably, as far as I'm concerned clinically, is a squamous cell carcinoma, is a carcinoma, unless I can disprove it by a biopsy. So let me repeat that. Any erythroplakic patch has got a very, very high risk of malignant transformation. And clinically, I tell the patient that there is a high risk of malignancy, and we need to rule this out using a biopsy. There are no two ways about it. In the case of leukoplakia, when there are no alarm signals, depending upon the clinical presentation, I really tell the patient that there is a risk of dysplastic changes, or that it may eventually become cancer, or there's a small chance that it may be cancer. So we need to see what degree of epithelial alteration is there on the surface mucosa. And of course, I use the lay term when I talk to the patient. I say what mucosal changes are there to see if you have a risk of cancer. Whereas in erythroplakia, I tell the patient that it is highly probable that it is cancer, and we need to disprove it with biopsy. So erythroplakic patches carry a very high risk of malignant transformation in the oral cavity, especially when associated with habits. And all the more so in oral submucous fibrosis, because normally oral submucous fibrosis, the mucosa is very pale and has fibrous bands. You don't see these sort of erythematous areas, except in the initial stages when it's because the patient has not discontinued the habit and there's a lot of stain because of the betel leaves which are used along with the areca nut. So this turned out to be a squamous cell carcinoma. Okay, Let me stop here, and I think I've kept well within my time. And let me quickly recapitulate the point which I tried to make today. The first case of amylogenesis imperfecta and a a central giant cell granuloma with a renal problem drives home the fact that systemic features are very, very important, and a thorough physical examination and all the vitalities to be checked, no matter what problem the patient has, how topical or local the problem may appear to be. The second problem with the headache, with multiple treatment the patient has undergone is no matter how subtle the lesion looks, if there is an organic change, it needs to be investigated and taken to its logical diagnostic conclusion so that the patient can be treated appropriately. The third case of melanoacanthoma, which is a rapidly increasing black lesion, the point is everything which goes rapidly and looks ominous is not necessarily ominous. And you need to be aware of these sort of lesions, and there's a lot of them in oral diagnostic practice, and you need to be aware of these lesions so that you don't overdiagnose and alarm the patient too much. And the fourth case was the liquid nitrogen burn, how new habits, and there are a lot of habits, including use of substances, substance abuse, cocaine, marijuana, and I think you can add liquid nitrogen to that. Of course, thanks to the COVID scenario, you may not see much of that. There's not much of partying going on, but you can have unusual habits causing unusual lesions, which if you don't diagnose with an appropriate history, coming back a full circle, history is very important. You may miss out the diagnosis. Histopathology, of course, is helpful, points you in the direction of elimination of likely causes so that you can come to a correct diagnosis and treat the patient appropriately. And finally, cancer can be tricky in clinical practice. A well-established cancer, classic clinical signs and symptoms, anybody can diagnose that. But when it is very subtle and associated with other problems, unless you have a very high index of suspicion and you're well trained, you may miss upon that. So whenever in doubt, either take a biopsy or refer them to a specialist so that the patient can be managed appropriately and in a very, very timely fashion. Let me stop here and hand it over to the host.
Thank you, sir. Absolute treat as always listening to you. Always enjoyable, and that has only improved with time. I must say, it is. If it was at all possible, it is. Every time I listen to you, it's better than the last. So,
Thank you.
sir, now you had a perfect collection. We covered right from what would be the most common problem in dentistry, being a periapical lesion, what would be the most scary thing for the patient, that is all the mucosal lesions. We had some new age disease, and we had some oral cancer. I also should make it a point to remind you, you have also mentioned two more lectures at least, so you are already committed to two more. Putting it on record.
Oh, that
Literally.
came with the flow, I guess. Okay. Yeah, and I curiously stayed
Yes.
away from my pet topics. I mean, you know that I talk about potentially malignant disorders and submucous fibrosis. But this is one of my passions, especially I jokingly say, the past few years I've been talking more to surgeons and practitioners and general pathologists because it's really interesting. Because I learn a lot from their feedback, and then they come up with, "Oh, doc, I had this case," and of course, I'm happy because my case file increases. Uh, but also, I think they go back, and ultimately, the patient benefits. And that's I think at the end of the day, that's why we are all here. No matter what research we do, or what we do, it's all patient centric. And I think if you don't lose sight of the fact, it's always fun to practice pathology in whatever form you're practicing. Yeah. So.
Absolutely. So let's see, are there any questions from the audience? I think everyone was so engrossed, no one has typed anything question wise. But now you can take the moment and put in any comments or questions you have. We are here. And Sir has marvelously managed to stay within the time, yes, which was great. So I'm basically working on reducing the time of the sessions. So you're the first one, and you have done an excellent job. I hope now subsequent speakers will keep to that. Okay, let's see. There seems to be something from Professor Joss. Yes. Hello. And also, the liquid nitrogen case is an eye opener. Yes. Patients do not always tell the truth. That is there.
Sure.
Uh, yes. And I like the way that you caught that from your knowledge, of course, of having seen frozen sections. That was really nice.
Yeah, yeah. Sometimes, these bits of information which are running around are useful. No information goes waste. But
Absolutely.
this involved a lot of talking with the patient actually, because what Dr. Hill has said, the IT people have a lot of habits. We are aware of that because they're in a lot of pressure, and their work timings are not really great, and we we see a lot of atypical habits both among women and men, which we normally don't see among the general population. So we need to ask all the questions and keeping in mind the cultural ethos of being an Indian. Like a lot of people, they will do it and they will not. And I think he's absolutely correct. And he's put it point blank. Sometimes patients uh, not tell the truth. They will conveniently forget to tell the truth. That's an act of omission. Rather than telling a lie.
Yes. Also, very often they feel that this is not relevant to a dental situation. I don't need to tell this to a dentist. How could this be related? So they make that decision, and then they sort of omit so many things. That is definitely there. And Professor Lee has one more question for you. Do you believe in Nico in the maxilla?
I was scared somebody's going to ask me that question. I have spoken to Jerry Boko a lot. I mean, I had the opportunity when I was at Ohio State, and he was one of the co-authors of the book along with Neville and Dan. I've spoken to him when initially he came up with the concept of Nico. I mean, he, he worked with orthopedic colleagues, and uh, that was the only case, as far as when I practice in India, I come across which sort of remotely resembles that uh, clinically. But obviously, it was not Nico. So I really don't have much experience to believe in that in the head and neck region. The orthopedic colleagues, some of whom I've spoken to, seem to believe in that very strongly. So hope I've answered that question usefully.
Yes. Sir, Dr. Garima is asking if you can show that case again.
Sure.
I think I will just add this to the stream and you can go to that slide.
I'm sorry I closed that. I think you want that. Let's see. I'm still sharing my screen, right?
Yes, sir. It's here.
Oh,
You
awesome.
just
Awesome.
have
Yeah.
to go to,
I
yes,
think, yeah. Um,
right.
those were the best picture. There were some lesions in the buccal mucosa too, but they were very, very subtle. Uh, there. So you can actually see these sort of, white areas. I presume it's a reaction to the liquid nitrogen burn. And then you can see these areas with uh, because of the deep burn, it has actually not epithelialized again. And that's what you saw in the histopathology. Okay, there's an interesting fact. Our colleagues in dermatology use liquid nitrogen to remove warts. This is very interesting because, once again, my prof, when I was doing my MS in the Ohio State University, Dr. Carl Allen, I must really thank him because my inclination towards clinical pathology is because of him. Excellent clinician and an oral pathologist. Um, we used to discuss about liquid nitrogen. We used to see he had quite a few dermatological cases in his files. The way liquid nitrogen works actually in warts is if you have an epithelial pathosis, it actually lifts the surface epithelium away from the underlying connective tissue so that the wart eventually sort of drops off. It will not work for a connective tissue lesion because the mechanism by which it works, it freezes the epithelium so that there's a separation of the epithelial connective tissue junction. And that's how liquid nitrogen works on a wart on the skin because of the human papilloma virus. And I guess that's what has happened here. Some of the epithelium sort of just peeled off from the underlying connective tissue. And in some places, there was so much damage that it hadn't healed. And that is why he had the burning sensation in those areas. And the other areas, it's probably just acanthosis and hyperkeratosis, which probably, given the turnover of the tongue epithelium, probably in 8 to 12 weeks, it would probably have healed off by itself. Provided he didn't irritate it further by applying, things like steroids, which would interfere with the healing once again, because steroids would not help in this situation because already there's an impairment of healing, and you don't want to apply steroids on top of that, which is what he was doing. Uh, is that okay? Do you want any other explanation on that? Or?
So there's another question from Dr. Arpan Shah. What is the treatment for the liquid nitrogen burns?
Oh, it is pretty straightforward. Tell him not to apply anything on the top. Apply some emollients on the tops, and allow him not to take spicy food or anything which irritates. And of course, some of us in India, we have the habit of cleaning the tongue, using a metal scraper or the toothbrush. Tell him to avoid doing that, and it eventually will reepithelize. And of course, avoid the habit which caused it. And this part of the world, I know we take a lot of spicy food. Avoid all that. Take a bland diet for a few weeks. And he did absolutely well. He stopped all the applications. And the moment he knew the answer, that it was only something to do with his habit, and that solved 50% of the problem. Because invariably, a lot of these patients have cancerophobia. Being in the IT industry, and I think everybody does that. It's not exclusive to the IT industry. We Google any of the clinical signs and symptoms. And non-healing white patch, which is increasing with ulcer, the first thing which will crop up is oral cancer, actually, if you Google it. Or one of the things which will crop up in your differential diagnosis. And that itself causes a lot of problem. And the moment he understands that, it is nothing ominous, that's half the battle won. And then he listens to you telling that, don't apply anything. So he understands that it's reasonable given what the diagnosis is. Yeah.
That is absolutely true. So we don't have any more questions coming in, but we have many telling you that it was wonderful.
Thank
So,
you.
look, yes, I shall share some of those. Yes. And I think we have had a lot of people watching on YouTube, not the ones who have put comments. I think mostly our oral pathology colleagues, but there are around 200 people watching. So
Oh,
I can only assume that our dental colleagues have not put a comment, but I do hope it has been useful to all of them, and that they enjoyed it and it's going to be useful in their practice as much as it has been interesting to us. So, yep, we are. There were lots of hellos in the beginning, sir. A lot of people came to see
hello
you
to
and said hello
everybody,
to all the
everybody.
colleagues. Yes,
And thank you for
absolutely.
this opportunity. It's been a pleasure, and thank you for the discussions. So we could narrow down on what we need to do, which is sort of really useful to our listeners. Thank you very much.
Thank you, sir. Thank you. You have done all the work. And you're coming back for at least two more. Actually, you promised me one more while we were discussing, and today two.
Yeah.
So I have a count of three lectures.
Okay, I will
I will
I will
call
I will
those
keep up
in.
my word. Yeah, I will do that.
Yes,
Okay,
okay. So, yes, so let me do this. Yes. And
thank you.
have we got this there? Yes. So, thank you so much, sir. It was not your first time on the channel, but nonetheless, this is the first time you have presented, and this was really nice. Thank you so much. Thank you.
Thank you very much. Thanks to everybody who has logged in, and all keep safe. We'll catch up next time around. Thank you again.
Yes, welcome, sir. Yes, thank you to all our listeners. It's been great having you here. And this is also when I share with you what we are going to do next. So next time it is going to be me on one more of our thinking out of the box series. I have two interesting topics. Have not been able to narrow down on which one, so I'm going to leave you in a little bit of suspense till then. But it's there, and well, we will meet. And in between, of course, the newsletter will tell you what it is. In the meanwhile, yes, have fun, enjoy your week, be safe, and see you back soon. Bye bye.